मेरा इंटरनेट तंग कह रहा था. I am sorry, I've corrected it. So we were discussing how we will treat a corneal ulcer. Right? So there's some general principles which we discussed the last time around on how we will treat a patient who has a corneal ulcer, and they include one, antibiotics and antifungals, or if we go a little broader, antimicrobials, which means that we need to control the infection. So the first important principle is we need to control the infection. In case of fungi, we will give antifungal drugs, topical nystatin, amphotericin, etc., etc. In the case of antimicrobial, in the case of bacterials, the antibacterials which we will use are tetracycline, ofloxacin, and other drugs. जो आपने याद करनी है. So control of infection is our first important principle whenever we're managing. Or what else? What are the general principles? What other general principles do we need to keep in mind?
Cleanliness.
Cleanliness. So cleanliness, it means that we advise the patient to clean his eyes with sterile saline, irrigate the eyes of sodium bicarbonate lotion. It keeps the organisms outside, and if there's any necrotic or purulent material accumulating, that's also gotten rid of. So cleanliness, it also means that the patient will observe hand hygiene. Third principle, or what else do we need to do?
Cycloplegia.
दोबारा repeat करना सर.
Cycloplegics.
Cycloplegics. Why do we use cycloplegics in corneal ulcers?
For pain.
For pain. So the use of cycloplegic comes under the heading of resting the eye. This is an important thing. Keep in mind what I'm about to say. Whenever you have a patient who has photophobia, you have to use cycloplegics. Photophobia किन दो चीजों में मिलता है? In which two diseases do we find photophobia?
Uveitis and
Uveitis, and the second is
corneal
one we're
ulcer.
discussing right now. Yes, corneal ulcer, the one we're discussing right now. So atropine, what it does is, atropine is an antimuscarinic. It relaxes the pupil. All right, it causes the pupil to dilate. What happens in the case of corneal ulcers is that inadvertently, whenever the cornea is involved, there is some anterior uveitis as well. In the case of bacteria, bacterial cause, and in the case of fungal cause, it's so much that it manifests as a hypopion. Otherwise, even if the toxins they enter or they penetrate the cornea, there will be some mild anterior uveitis. So in anterior uveitis, the inflammatory mediators are released from the vessels in the iris, and vessels are dilated. What we need to do is we need to constrict those vessels so that they don't release their inflammatory mediators. And if there's any tension in the iris, we have to relieve that tension as well. This is where atropine comes in. Atropine क्या कहती है? Cycloplegics means atropine is the most important. Atropine, what is that? It does that. It relaxes the ciliary muscle, which in turn decrease the vasodilation in the vessels of the iris, which in turn leads to a decrease in the release of pain mediators. Atropine is very important. It's very essential. If there is one drug which is essential in corneal ulcer, which is the mainstay of treatment of corneal ulcer, that is atropine. You have to remember this. This is an MCQ. If there's one drug which is important for the treatment of corneal ulcer, that is atropine. Atropine, it rests the eye. It decreases the photophobia. It relieves the blepharospasm, and it's very important for symptomatic treatment. So we have to rest the eye, atropine. Any other general principle on which we should follow?
Surgery is complication.
Complications, right? complications. But there's one more thing which I think I forgot to mention last time. That is that we need to protect the eye as well. In corneal ulcers, environmental exposure in an eye which has corneal ulcer, environmental exposure can be harmful for the eye. So what we need to do is we need to protect the eye. When we protect the eye, we can protect the eye either by simple use of sunglasses and shades, which protect from dust and all of the sort of that stuff. And if the corneal ulcer is severe, we can pad and bandage the eye. What it does is it कहता क्या है bandaging the eye, it closes the eye. So the ulcer can heal in a closed environment, in a better environment. So an MCQ which arises from this question, this general principle of treatment is that we do padding and bandage of the eye in cases of corneal ulcer. Can we do the same for a conjunctival condition? For let's say if we have severe conjunctivitis, can we do the same? The answer of this is no, not done in conjunctivitis. Because in conjunctivitis, there's a lot of pus which is accumulated in front of the conjunctiva, in the eye, in the fornices. So if we have heat and we close that area, it becomes a sort of an incubator. जिसके अंदर bacteria can grow in that pus. So basically, culture medium आप उन्हें बना के देते हैं. And that is why pad and bandaging is only done in corneal ulcer. It's not done in conjunctivitis. Lastly, we have to treat the complications and the things which arise with the complications. Complications we will discuss once we're done with these ulcers. So briefly reviewing hypochondrial ulcers, if you're given a statement in which there's symptoms of photophobia, redness, and tearing, and you have a hypochondrial ulcer, you will either suspect a bacterial nature or a fungal cause. Look for context clues such as thorn prick or steroid use. Then you will look for the description of the ulcer itself. It can be a ulcer with wavy margins which may creep across the cornea, or it can be a large ulcer which has satellite lesions, hyphae growing under the cornea, and an immune ring present. Based on that, you will form your diagnosis, and then you will treat on the basis of these principles. Antimicrobials or control the infection, clean the eye, rest the eye with atropine, protect the eye, and the last is manage the complications. So this was, these were our two etiologies which were important, fungal and bacterial. Now the third. Our third case for today. It's a patient who presents with redness, photophobia, and tearing. All right. Nothing peculiar about that. Typical history here: photophobia, tearing, and redness. When you perform the examination of this patient, this is what you see. So the first thing, is it a hypochondrial ulcer?
No.
No, it's not a hypochondrial ulcer. So at our level, considering UHS and examinations, if it's not a hypochondrial ulcer, it's unlikely it's bacterial or fungal. So you've ruled out two causes. Now look closely at this ulcer. The first thing is you can appreciate is the color. It's green. Why is it green?
Because of the stain.
Because of the stain, because of sodium fluorescent stain. So a sodium fluorescent stain is staining an area in the cornea. So it's a corneal ulcer. Look at the lesions. How are they different from the previous two we saw? Well, let's talk about this one. We can see that there's branching. What do we mean by branching? There's somewhat of a central body around here. And this staining which shows a branching pattern. One branch, it gives off an offshoot, it goes away, it gives off an offshoot. And similarly, there's a branching pattern. So we have an ulcer with a branching pattern. And what do we have over here? We have a large ulcer. We have a large ulcer. And it doesn't have branching pattern except over here, which it replicates the pattern which we saw over here. All right. So in our patient, when we perform an examination, we see that there's an ulcer. There's two ulcers basically. So the ulcer at the bottom or the lower ulcer, it shows a branching pattern. This branching pattern, due to this branching pattern, this ulcer is called a, what is it called? Does anyone know?
Dendritic.
It's called a dendritic ulcer. Dendritic ulcer is a buzzword. You have to remember this. So the inferior lesion shows a branching pattern. It's a dendritic ulcer. But what is the superior lesion? So the superior lesion,
Geographic.
it's a geographic ulcer. Yes. So what is a geographic ulcer? When dendritic lesions, they coalesce. Coalesce meaning that बहुत सारे dendrites थे and they join together. They form a geographic ulcer. Geographic ulcer के लिए एक और term भी use होती है. से निकल रही है. Doesn't even know. चलो अगर मेरे ज़हन में आती है तो I will let you know. So we've just seen two things. The first is a dendritic ulcer, which forms a branching pattern, and the second is a large confluent ulcer, which shows some dendrites as well. These two lesions, whenever they will be given to you, they are characteristic of. They are characteristic of. मेरा इंटरनेट भी खराब हो रहा है, मैं खुद पॉज कर रहा हूँ. What are they characteristic of?
Viral.
Viral. So, geographic ulcers and dendritic ulcers. These are characteristic for viral ulcers. कौन सा viral ulcer होगा? Geographic ulcers are also called confluent ulcers. So, what are the viruses which we have discussed that infect the eye?
Herpes.
Herpes. So our diagnosis is herpes simplex keratitis. Herpes simplex is a virus in the herpes family. Herpes simplex 1, HSV1 or HSV2 can cause this lesion. It's an ulcer, but herpes simplex, it can also cause many other lesions. They include superficial punctate keratitis. They include interstitial keratitis, and if it's severe, it can present as a dendritic ulcer or a confluent ulcer. These are called dendrites because they resemble the dendrites of an axon. If this is an axon body, then these are all the dendrites. All right. So there's many things which herpes simplex virus can cause. The important thing from an examination point of view, especially in OSPEs and in MCQs, whenever herpes simplex will be discussed with you, it will be in the context of a dendritic ulcer or a confluent / geographic ulcer. Another peculiar feature, another peculiar finding, which can be given to you in this case, is that this patient will have corneal anesthesia. Because of the destruction of the nerve fibers by the herpes simplex virus. There's also a predilection for age. I want you to tell me that. Herpes किस age group में ज़्यादा होता है? For primary herpes, mucosal herpes, which is the age group of patients who have primary oral herpes? Infants and children, right? Infants and children. So a primary herpes infection, it most likely, it's mostly occurs in children. And that is one of the demographic that is affected by dendritic ulcers. So an ulcer with a branching pattern or a large confluent ulcer with a branching pattern, a dendritic ulcer or a geographic ulcer. they will point you towards a viral etiology or a viral cause. Now, herpes has its own treatment and herpes has its own diagnosis. You can use the Zank smear. आपने Zank smear पढ़ा होगा. Zank smear is used, otherwise immunofluorescence is used to detect herpes simplex virus. The treatment, again, it will be on those principles which we discussed. Instead of antimicrobial, we will have antivirals. Which antiviral we will use? We will use acyclovir. Acyclovir, cleanliness, resting of the eye, protecting of the eye, and treatment of any complications if they arise. So, this was our first case. Now moving towards our second case. Our patient, she complains of redness, photophobia, and tearing. We know that, all right, the cornea is being affected. When we talk about tearing in this context, specifically, what is this tearing? Tearing of the eye, आंसू आ रहे हैं आंखों में. There's another term for this. Whenever the patient presents with watering or tearing of the eyes, आंसू आ रहे हैं, it can either be lacrimation or it can be epiphora. In this case, this tearing is it's lacrimation. Okay, so keep that in mind. Epiphora कहाँ होता है, lacrimation कहाँ होता है. Is there anything peculiar in the history of this patient?
Eruptions. Physical eruptions.
History, yes, the physical eruptions. The physical eruptions, they're very important. Presents to you with vesicular eruptions along her face. I forgot to write one important thing in the history. This patient has a history of chickenpox. So patient has a history of chickenpox and she presents to you with vesicular eruptions along her face. And she has symptoms of corneal affliction as well. So there's a history of chickenpox, there's vesicular eruptions. So the disease entity with vesicular eruptions after the patient has had chickenpox. It's called, do you know the name of this disease?
Shingles.
Shingles, exactly. This is shingles. Shingles, the other name of shingles is?
Zoster.
Herpes zoster, yes. Herpes zoster. Herpes is caused by the varicella zoster virus and it's called herpes zoster. So, our patient, when we perform her distant examination, दूर से हम जब उन पे उन्हें देखते हैं, so she has vesicular eruptions, right? She has some discharge, so it's conjunctivitis as well, and she has the symptoms which tell us that okay, there's a corneal affliction as well. What is peculiar about these eruptions?
Location.
Location. Okay, comment about the location then. Where are these located?
Ophthalmic nerve. जहाँ supply करती है.
जहाँ supply करती है, बिल्कुल. So herpes zoster or varicella zoster virus, it lies dormant in the nerve roots. So if it lies dormant in the trigeminal distribution of the trigeminal nerve, specifically the ophthalmic division, it will present with vesicular eruptions in the distribution of the nerve. These vesicular eruptions will abruptly halt in the midline. They will not cross the midline. Okay? And secondly, the tip of the nose and the area of the nose will always be involved whenever the cornea is involved. This is a small association, buzzword association, you should keep in mind. This area is supplied by the nasociliary nerve. Achha. So on examination, unilateral hoga. It's unilateral. If it were to be bilateral, then we would find the same vesicular eruptions on the other side as well. So it's unilateral. That is why it's abruptly stopping over here, or it's restricting itself to one half of the superior part of the face.
लेकिन bilateral भी हो सकते हैं ना?
Bilateral हो सकता है, but the presentation is unlikely. Whenever we say that a patient suffers from herpes zoster, the vesicles, they usually affect only one nerve root or nerve trunk, and they affect a specific dermatome. So it can be bilateral if both the nerves are affected, but it usually affects nerve roots on one side. And that is why it's unilateral. आपको जो cases मिलेंगे उसमें unilateral ही आएगा. Nerve root एक effect होती है इसमें. It affects the nerve roots, not the spine. Nerve root फिर एक तरफ की होती है जो affect होती है. And that's why it's unilateral. I don't remember if I've read anywhere that it's bilateral.
असल में हमने वार्ड में देखा था एक bilateral केस.
हो सकता है फिर. I may be wrong. Yes, बिल्कुल हो सकता है. So vesicular eruptions with corneal symptoms and conjunctival discharge. Conjunctival discharge because there's a element of conjunctivitis as well. This disease, in the history of chickenpox, this disease is termed what? Herpes zoster ophthalmicus. This is the diagnosis, the buzzword diagnosis, which everyone is looking for in Viva. And this will be given to you either in the MCQ as an option, or herpes or varicella zoster virus, VZV, will be given to you. So herpes zoster ophthalmicus caused by VZV, varicella zoster virus. You have to remember this, keep in mind whenever you're doing, because some of the times we know the MCQ, we know the answer, and we know that, okay, it's herpes ophthalmicus, herpes zoster ophthalmicus, and we see HSV1, और जल्दी में हम HSV1 टिक कर देते हैं. Herpes zoster ophthalmicus caused by varicella zoster virus. This is the history, or typical history of a patient who will present. Patient will have vesicular eruptions. The patient will have a history of chickenpox, present with symptoms of corneal affliction and vesicular eruptions. On examination, the vesicles will be restricted to one dermatome. This is our case of herpes zoster ophthalmicus. In herpes zoster ophthalmicus, a patient can have a dendritic pattern as well. But there's an important differentiation between the two. So if you look closely at the terminal portion of these dendrites, if this is a dendrite, the terminal portion of this dendrite is round. It's not tapered off. Similarly, the dendrites over here, and over here, if you look at the twig in between, and you look at the terminal parts of the dendrites, you will see that these dendrites, they are rounded at the ends. This is typical for herpes simplex virus. If a patient of ophthalmicus presents with dendritic ulcers, their dendritic ulcers will have tapering ends. They will not be round. Meaning that, इसको draw कर लेते हैं. If a patient of herpes zoster ophthalmicus has dendritic ulcers, the end of the dendrites will be tapering like this. Compared to a patient who has herpes simplex virus, the ends of his dendrites will be rounded, or they will have flaps. Can you appreciate the difference? Okay, this is one of the clues or differences which are not exactly high yield, but they're good to know. Secondly, this is another lesion in which patients of herpes zoster can present. If you look closely, there isn't any corneal ulcer in this condition. However, we can appreciate corneal opacities, especially in the ray or in the slit lamp. What is the shape of these opacities? The shape of these opacities, they are rounded. All right? So it's a rounded affliction of the cornea. These are rounded lesions which are not present on the surface. So it's not a corneal ulcer. They are present deep. So it's a keratitis. If we perform, when we see on the slit lamp examination, we know that they're present in the deeper layers. And these circular lesions, rounded lesions, when present in the deeper layers, they form a keratitis called nummular keratitis.
ये केरेटिक precipitates है.
नहीं, keratic precipitates नहीं है. Keratic precipitates are seen on the back surface of the endothelium. Endothelium पे होते हैं, cornea के अंदर नहीं होते. ये दरअसल slit lamp की beam को आप देखें. This is the slit lamp beam. ये. They are present inside the cornea. Circular lesions present inside the cornea. Nummular means circular or coin-like. These are coin-like lesions inside the corneal stroma. So nummular keratitis. This is present in herpes zoster ophthalmicus. Right? It gets a little confusing after a while. So that's why I'm referring कि ज़्यादा important जो important चीज़ें इनकी वही discuss करें, बाकी हम ना discuss करें. So these we saw 4 cases today. 2 of hypopyon ulcers and 2 of viral ulcers. Reviewing the viral ulcers again, our patient, we will look for context clues. The first important context clue is whether this patient has a hypopyon or not. So if a patient does not have a hypopyon, it's unlikely that the cause is bacterial and the cause is fungal. Fungal or bacterial, हमने side पे रख दिया. Next, any other context clue? Is there a history of chicken pox? Is there a history of vesicular eruptions around the face? If there is, then it's herpes zoster ophthalmicus. If there's no history of these afflictions, all right, on examination, we find a dendritic ulcer, meaning patterns, dendrites are arising, or it's a branching pattern. Or if we see a confluent ulcer, a large ulcer, a confluent ulcer or a dendritic ulcer without the presence of a hypopyon, this will tell us that, all right, it's not herpes zoster ophthalmicus. This is herpes simplex virus. So we've done 1, 2, 3, 4, 5, 6, 7, 8, almost 10 organisms, 3 bacteria, 3 fungi, and 2 viruses we've discussed. And the presentations or typical lesions of the corneal ulcer caused by these viruses. There are 2 more infectious etiologies which I want to discuss, but should I discuss them right now or should we discuss them in our next session?
अभी कर लें if everyone agrees.
चलो अभी कर लेते हैं फिर. All right, so viral or hypopyon. Next 2 cases. Let's discuss this case first. Our patient has a history of redness, photophobia, and tearing. Tearing, it means lacrimation. Photophobia, redness and lacrimation. It means that it's a corneal affliction. It's something that's affecting the cornea. What is the other peculiar thing important in this history?
Contact lenses.
She uses contact lenses. First important thing. Or क्या important है?
And wash उसको tap water से कर.
Reports using tap water instead of sterile saline for her lenses. For those who don't use lenses, lenses are stored in sterile fluid whenever we're not using them, those soft lenses. So this patient, she's trying to be frugal. पैसे बचाने की कोशिश कर रही है. She uses tap water instead of the water which comes with the lenses. So we have a very important context clue. And sometimes only this context clue is given. There is no history, no other history except for which points towards corneal ulcer. And you get typical history corneal ulcer की दी होगी. And there's nothing else given. There's no examination, there's no treatment. They just want you to tell the organism. Which organism causes corneal ulcer in contact lens users who use tap water instead of sterile saline?
Acanthamoeba.
This is a parasitic corneal ulcer caused by Acanthamoeba. Acanthamoeba. I don't know the spelling as well. So Acanthamoeba keratitis, or if there's an ulcer, Acanthamoeba corneal ulcer. This, the only thing which you have to know is that it is an ulcer or it is an inflammation or अगर ulcer है तो ulcer वरना keratitis caused in contact lens users who use tap water instead of sterile saline, and the cause is acanthamoeba. This is the only important keratitis of the parasites you have to know. Okay, there is nothing else important that other than these things. Contact lens users who use tap water. Examination, it won't be asked, but there's a ring of infiltrate in the cornea. Usually acanthamoeba, it presents as a keratitis, not as a corneal ulcer. And in the keratitis, it won't stain with sodium fluorescein, but you will see a ring. Can you see this ring around the cornea? These are the margins of the ring. There's a ring of an opacity or an opaque ring, and the centers are somewhat clear. This is what you will see in acanthamoeba keratitis, but again, remember this, contact lens users who use tap water. Which was the conjunctivitis which we discussed was caused by contact lenses? What's the conjunctivitis?
Giant papillary.
Giant papillary conjunctivitis. And the papilla in giant papillary conjunctivitis, they're greater than 2 millimeter or centimeter, I'm forgetting. So the only important parasitic ulcer. And again, it's another bacterial ulcer, but it does not present with hypopyon, but it has a very peculiar history. So discussing this history, the patient has photophobia, the patient has redness, the patient has staring. And he will also have blepharospasm, corneal, these are symptoms of corneal affliction. What else is important in this case? What do we find is important in this case?
Chronic hai.
Chronic hai, the first thing is that, all right, it's chronic, couple of months chal raha hai.
And history of chronic blepharoconjunctivitis.
Blepharoconjunctivitis in the same eye. This is a very peculiar history. You have to remember this. If you remember the history, you can easily remember this. So our patient, चलो फिर examination कर लेते हैं, case review कहते हैं. So on examination, we have a corneal ulcer. How do we know it's a corneal ulcer? It's staining green. And this green stain, it is at the margin of the cornea. Can you appreciate that it's at the margin around the limbus?
Yes.
Right? So this ulcer is at the margin over here. So an ulcer at the margin in a patient who has a history of chronic blepharitis or chronic conjunctivitis, our diagnosis will be
Staph.
The organism is Staph aureus. You are correct. The organism is Staphylococcus aureus. So,
diagnosis will be marginal ulcer.
Marginal ulcer. Staphylococcus aureus causing a marginal ulcer. The important thing in a history of marginal ulcer is that the patient will have a history of chronic blepharoconjunctivitis. जो पेशेंट आएगा मार्जिनल कॉर्नियल अल्सर के साथ, एक तो मार्जिन पे कॉर्नियल अल्सर होगा, he will have a corneal ulcer at the margins. He will have a history of chronic blepharoconjunctivitis in the same eye. So these are all of the infectious corneal ulcers or keratitis, because one is a keratitis, which we have to remember, which are high yield for us in professional examinations in vivas. मेरा जो इस बार ophthalmology का viva हुआ था, the examiner, there was an external examiner, and what he did was he was showing different pictures to different students. All right. So the picture he showed me was most probably this without the arrow. He told me to tell me what this is. So I described, okay, so this is a corneal ulcer because the patient has a hypopyon. is a sodium fluorescein staining corneal opacity, and this circumciliary congestion. So it most likely a hypopyonis. So he said, okay, what are the causes of hypopyonis? I told him there are two causes of hypopyonis. It can either be a bacterial or it can either be a fungal. He said, ठीक है. एक बंदा आया, उसको गुलाब का कांटा आंख में चुभा और उसके बाद उसे ये हो गया. What will your diagnosis be? It will be fungal corneal ulcer. I said, all right. If the same patient, he has a bacterial cause, what will your diagnosis be? It will be pneumococcal corneal ulcer. He said, all right. So a patient who presents to you with a corneal ulcer and she wears contact lenses, what will your diagnosis then be? ये आप बताएंगे. Parasitic, and the organism will be Acanthamoeba keratitis, and he said, all right. So buzzwords and associations, they're very important because in Vivas, अगर आपको वो buzzword नहीं आता, you won't be able to know the organism, you won't be able to know the disease itself. Hypopyon ulcer, we have two etiologies. Dendritic ulcer or geographic ulcer, again we have two etiologies, but one is more important. Then we have keratitis or ulcer associated with blepharitis. Then we have keratitis associated with contact lens tap water. These are some associations or some important context clues which will help you massively if you remember these and the diseases which these are associated. Last is ulcer with history of chickenpox. Review these things and review these associations. अगर आपको ये याद रह जाएंगी तो corneal ulcer easily हो जाएगा. ठीक है? So again, remember geographic and dendritic ulcers, they're associated with viral etiologies. Hypopyon ulcer, bacterial या fungal. Parasitic एक important है, and that is Acanthamoeba. And Acanthamoeba causes keratitis in contact lens users who use. This is all from for today's session. Do you have any questions? किसने कुछ पूछना है?
No.
No. समझ आ रही है आपको? Are you guys understanding? Have you understood what we've discussed today? Have you understood what we discussed yesterday? Because that is the important thing. बाकी चीजें, facts and figures आप लोग पढ़ लेंगे. You won't have any difficulty in memorizing it. You've done it so far, you can do it again. And the important thing is that you take something away from these lectures. Either remember the pictures, either remember the histories, the context clues. आपको कुछ जज़ब होना चाहिए. You should absorb something. If you think that you're not absorbing, do let me know. I will try to make it better या कुछ बेहतर कर सकें. If you have any suggestions, also do let me know. Okay? Because the main aim of these sessions is that you develop a better understanding of how to tackle clinical vignettes in cases. So with that being said, we end our today's session. If you have any feedback or suggestions, feel free to tell me or message in the group. And if you have any questions also, again in the group. So we will finish. And the next time we will discuss the complications of a corneal ulcer. And then we will discuss another important condition, keratoconus. Do read up on it. So take care guys. Have a good Ramzan. इबादत करना आज ताकना आता है. मुझे लगता है आज ही है. तो सबके लिए